الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, I have changed some of the presentations, and I tried to add some of the recent issues which are necessary for you to know, and this was applied for the topic of diffuse lung disease. I have made a lot of changes in this topic, and also here I will make some of the changes in the topic of pulmonary vascular lesions, and this topic will be divided into two parts. The first part will be presented now, inshallah. As you all know, the extreme value of the multi-detector CT in assessment of the vasculature all over the body, and its value in assessment of the pulmonary vascular lesions. You all know that this multi-slice CT allows very rapid scanning. It allows also vertical reconstruction, vascular imaging in a relatively non-invasive way, and also it allows the virtual endoscopic evaluation. By multi-slice CT, we can inject intravenous contrast material and image the lung whenever the contrast material is concentrated in the pulmonary artery, and we have axial images, coronal and sagittal images to see, as you can see here, the pulmonary vasculature. Also, you may have these images in color, and you can see the main pulmonary artery, its central branches, as well as most of the peripheral vascularity. You can subtract any of the undesired structures in the image, like the ribs, and you can remove the lung parenchyma, you can remove the spine, you can remove the trachea and esophagus, for example. Then you can easily examine the pulmonary vasculature, as you can see here. Then these are the items we would like to talk about: the pulmonary embolism and this recent topic which is known as chronic thromboembolic pulmonary hypertension. Then we'll talk about pulmonary hypertension. In the second part of this topic, we'll have some words about pulmonary vasculitis, pulmonary aneurysms, arteriovenous malformation, and finally the pulmonary artery neoplasm. Then we'll start by the pulmonary embolism, and here are the risk factors, which include the age, of course, obesity, and the smoking, which is related to many of the thoracic diseases. Also, the bed rest after surgery or chronic illness, for example, a long trip by car or plane, and major surgeries like joint replacement of the knee or the hip, peripheral artery disease, cardiac disease, and the family or personal history of venous thrombosis, some of the contraceptive pills, and hormone replacement therapy. Actually, there are a lot of ways to assess or to diagnose pulmonary embolism, and these included the nuclear scanning, pulmonary angiography, which is this digital subtraction or conventional angiography, the MRI, and the CT pulmonary angiogram. I have said that the CT pulmonary angiography is the most sensitive technique to detect pulmonary embolism, and this is true only in acute conditions. CT pulmonary angiography is considered the reference standard in acute pulmonary embolism, but whenever we came to the second issue, which is the chronic thromboembolic pulmonary embolism, and then we'll have different ways of assessment. Okay, in the ventilation and perfusion scans, there should be a good match between the ventilation and the perfusion scans. And if there is a mismatch between the perfusion and the ventilation scans, we'll suspect the pulmonary embolism, as I will show to you. Considering the chest radiograph, the X-ray findings in a patient of acute pulmonary embolism may be absolutely normal, or it may show a wedge-shaped opacity like this one, which is referred to as the Hampton hump configuration, with the apex pointing medially and the base is towards the chest wall. Or you may find some basal atelectasis, and also you may see pleural effusion. And these are the traditional non-invasive ways for evaluation of pulmonary embolism, including the clinical examination, that's chest radiograph, echocardiography, arterial blood gases, assessment of the lower limb venous system, and the radionuclide scans. And if you look to this chest X-ray, you can hardly see a lesion. This patient had an Achilles tendon rupture 4 weeks previously, immobilized, and developed increasing shortness of breath. Then the chest radiograph looks normal. On the multi-detector CT scan of the chest with an axial and coronal reconstruction showed multiple filling defects in the right main pulmonary artery, diagnostic of pulmonary emboli, and also you can see some filling defects in the left side as well. Then if you look here, you can also see some prominence of the hilar shadow with peripheral attenuation of the lung markings, but the chest CT showed that this branch is occluded. There is no contrast material in this artery, and also you can see the corresponding opacity in the lung representing a pulmonary infarct. And this patient with breast cancer developed acute chest pain and hemoptysis, and the CT scan showed a large filling defect in the main pulmonary artery on the left side. The lung window shows 3 opacities in the lingula and the posterior segment of the left lower lobe representing pulmonary infarcts. Then the saddle thrombus is a big thrombus which involves both main pulmonary arteries crossing the bifurcation. This is known as a saddle embolus. Pulmonary embolism was also diagnosed by selective conventional or DSA aided pulmonary angiogram, and this is the catheter introduced into the left lower lobe pulmonary artery branch, showing multiple filling defects within the artery with non-filling of the peripheral vessels. Massive pulmonary embolism may be seen on multi-detector CT as multiple filling defects involving the major arteries of the pulmonary artery, and you see here a filling defect in the right main pulmonary artery, 2 filling defects in the left main pulmonary artery representing multiple pulmonary emboli. Then one of the values of the multi-detector CT is its ability to see the peripheral branches, requiring a good high resolution. Then you see a filling defect in one of the peripheral branches of the pulmonary artery, diagnostic of peripheral embolus. Then what are the findings of pulmonary embolism on a multi-detector CT? Number 1, an intraluminal filling defect like this one, complete obstruction of one of the arteries, which is less common. Large clot are usually elongated, meaning that it extends for a good segment. Saddle embolus may be seen crossing the bifurcation of the pulmonary artery, and the small distal emboli are somewhat difficult to be seen. And this is a reformatted image of the main pulmonary artery and its central branches, and you can easily appreciate the absence of contrast enhancement in this lower lobe branch on the right side, diagnostic of pulmonary embolism. Then care should be taken whenever interpreting a case like this in order not to interpret this as an pulmonary embolus. On the right side, there may be an artifact or a misinterpretation of this lesion to be inside the pulmonary artery. If you have the coronal reconstructed image, you will see that the pulmonary artery, its upper lobe and lower lobe branches are patent, and this lesion was proved to be a lymph node in the mediastinum. Then care should be taken whenever interpreting pulmonary embolism, especially on the right side related to the right main pulmonary artery. But in this case, and you see this is the right main pulmonary artery, and you see a filling defect here, and if you look to the lung window and you see a pulmonary infarction, then this is an intraluminal thrombus, diagnostic of pulmonary embolism. Then if you have high resolution images, good contrast enhancement, and reformatted scans, and you can appreciate the vessels containing emboli, which are less enhancing compared to the patent normal vessels pointed to by the yellow arrows. Then if you have a problem with contrast injection in the CT scan, if the patient is known to have a major hypersensitivity to contrast material, or is known to have renal troubles, then you may have the advantages of MRI, and considering that MR can perform pulmonary angiogram without the need to inject contrast material, you may obtain a very good image, but consider that the time is a little bit longer compared to the time of the CT scan. And if you compare this coronal reformatted CT multi-detector CT scan of the chest in a patient with left-sided pulmonary embolus in the lower lobe branch, and the same by MRI, and you can see the same finding by both techniques. Then if the embolus is chronic, it will have an eccentric position within the vessel, and you got some patency of the vessel compared, and the embolus is eccentric. Then you would expect that the initial scan of pulmonary embolism will show the embolus in one of the vessels, and it is expected after some time, let us say the range of 10 days for example, that you may feel that the embolus will increase in size because of the aggregation of the blood behind the true embolus. And whenever the embolus is chronic, it will have an eccentric location in the vessel with the patency of some of the vessel lumen. Other emboli can enter the pulmonary circulation, and this is air embolism, which is now frequently seen in the clinical practice after the use of automatic injectors, which can lead to some injection of air with the contrast material, and it will appear like this in the pulmonary artery. Then septic emboli, which means that there are embolic material containing microorganisms like bacteria or fungus or even parasites, and this is a common situation in patients with infective endocarditis. The showers of emboli will reach the pulmonary circulation and will result in too many pulmonary nodules, which will show some cavitation. And these are the predisposing factors for septic pulmonary emboli. The major issue is infective endocarditis, drug addiction, alcoholism, skin infection, immune compromise, and infected catheters, like the central venous line, for example. Then septic emboli will appear like abscesses in the lung. They have relatively thin wall, and they may contain air, or maybe if they are large, they may show some air fluid level. while the smaller emboli will appear as solid nodules. Then if you look to this chest radiograph, and you can see multiple cavitating pulmonary nodules scattered throughout both lung fields. Then you need the clinical data to reach the specific diagnosis, because multiple pulmonary cavitating nodules have a very long list of differential diagnoses I will mention in a moment. Then the pulmonary nodules will appear solid if they are small, and they will cavitate if they are a little bit larger. Lesions are usually numerous in the lung bases, as you can see here, and if you follow every lesion, and you can trace it centered over one of the pulmonary vessels. Then this patient is known to be an intravenous drug abuser and heavy smoker, developed fever, virulent infection near the right calcaneal tendon. The chest radiograph was normal 1 month earlier, but now it shows some nodules in the right side of the lung, and the high resolution CT showed 2 cavitating pulmonary nodules, diagnostic of septic emboli. And this patient is 44 years old with too many cavitating pulmonary nodules. He is known to be an intravenous drug user with developed fever and dyspnea. The CT scan showed the classic appearance of numerous septic emboli scattered in both lung fields. And here is the differential diagnosis of a cavity or a cavitating nodule inside the lung. And you can use the abbreviation of the cavity to remember the differential diagnosis. Number 1, carcinoma, including the squamous cell carcinoma, also lymphoma and metastatic deposits, autoimmune diseases like Wagner and rheumatoid nodules, vascular lesions like septic emboli, infection by bacteria or fungus, trauma. The lung laceration will appear as a cavity, if you remember this, and young, which stands for congenital, including the sequestrated lung segment and congenital cystic adenomatoid malformation of the lung. Then we came to this important issue, which is known as chronic thromboembolic pulmonary hypertension, or CTAF. This is a well-known disease which is seen more in females with history of cancer or hypercoagulable disorders, in patients with known history of pulmonary embolism or previous surgical removal of the spleen, and some of the chronic inflammatory diseases like inflammatory bowel and osteomyelitis. And patients with CTAF may have no symptoms at all. When symptoms develop, they are vague and they are non-specific, including dyspnea on exercise, chest discomfort, and fatigue. Symptoms of later stage disease include fainting and signs of right-sided heart failure. Some patients with CTAF never have any symptoms at all. Then, whenever CTAF is suspected, any patient with unexplained pulmonary hypertension should be subjected to a CTAF evaluation. And this evaluation includes the chest radiograph, echocardiography, ventilation perfusion scan, right-sided cardiac catheterization, CT or MRI, pulmonary angiogram. Then the chest radiography may show signs of pulmonary arterial hypertension. You all know the enlargement of the main pulmonary artery segment, dilatation of the central branches, and the peripheral attenuation of the vascular markings. Then echocardiography is not specific for the diagnosis of CTAF, but it helps to assess the pulmonary artery pressure, excludes an intracardiac shunt, and excludes left heart disease as a cause of pulmonary arterial hypertension. The signs seen in patients with CTAF by echocardiography include right ventricular and right atrial dilatation, right ventricular pressure overload, and tricuspid regurgitation. This is the recent guidelines provided by the European Society of Cardiology and the European Society Respiratory Society recommended a follow-up echocardiography in patients with acute pulmonary embolism showing signs of pulmonary arterial hypertension. Then the ventilation perfusion scan is the basic tool for diagnosis of CTAF, and a normal ventilation perfusion scan rules out the diagnosis of CTAF. About 99% of patients with CTAF or chronic thromboembolic pulmonary hypertension had abnormal perfusion scans in the form of multiple perfusion defects, which are of course not matching with the ventilation scans. And then the absence of perfusion to one lung. If you perform the ventilation perfusion scan and you got total absence of perfusion in one of the lungs, and this is not CTAF, but you think of any other disorders like malignancy, mediastinal fibrosis, or vasculitis. Then this is the ventilation scan and this is the perfusion scan, and you can see multiple perfusion defects which are not corresponding to defects in the ventilation scan. And this is one of the rules, as the number and the size of the defects in the perfusion scan of course decreases, then the accuracy of the test also will decrease. And this is multiple perfusion defects in both lungs by perfusion scan in a patient with chronic thromboembolic pulmonary hypertension. Then it is a good policy in patients who develop the pulmonary embolism that they should be followed for fear of the development of pulmonary arterial hypertension. And this follow-up should include the chest radiograph, the ventilation perfusion scan, which is very important, and the echocardiography. CT pulmonary angiography will show the emboli, like I have presented previously, as filling defects within the pulmonary vessels. Also, it may show dilatation of the proximal pulmonary arteries, dilatation of the right cardiac chambers, right ventricle and right atrium, and it may show mosaic perfusion pattern, areas of increased attenuation or ground glass opacities, and areas of air trap. Multi-detector CT angiography has also shown to be less sensitive than perfusion scan in detecting of chronic thromboembolic pulmonary hypertension. If you look here, and this is the main pulmonary artery, the left side and the right side shows eccentric emboli denoting chronicity, and the lung window shows patchy areas of ground glass opacities scattered in both lung fields. The hyperlucent areas are those which are ischemic, and those are the perfused lung tissue. Then, if you have a clinical suspicion of CTAF, then you proceed for echocardiography, and you see right ventricular dysfunction and more than 3 months of effective coagulation in a patient with previous history of pulmonary embolism. Then you go to perfusion ventilation scan. If it is negative, no CTAF. If it is indeterminate, there is a question about CTAF. If you detect at least 1 or 2 segmental large size defects, then the diagnosis of CTAF is most likely, and you proceed to right cardiac catheterization, or to do pulmonary angiogram, or to have a CT or MR angiogram. Then you can see the signs of CTAF, and then you proceed with long life anticoagulation. Then we shift to the third issue. We have finished the pulmonary embolism, and and chronic thromboembolic pulmonary hypertension. Then we came to pulmonary arterial hypertension. There are a lot of causes for pulmonary arterial hypertension, include the idiopathic causes and some of the drugs and congenital heart disease, connective tissue disorder, HIV infection, left-sided valvular heart disease, chronic obstructive pulmonary airway disease like emphysema and fibrosis, lung diseases such as pulmonary fibrosis, sleep apnea and other sleep disorders, long-term exposure to high altitude, the chronic thromboembolic pulmonary hypertension, and also blood disorders, metabolic diseases, and the tumors. Then pulmonary arterial hypertension is diagnosed by the enlargement of the main pulmonary artery segment and the dilatation of the central branches with peripheral attenuation of the pulmonary vascular markings. A distal main pulmonary artery trunk diameter of more than 29 millimeter or more, exceeding that of the ascending aorta, has a positive predictive value over than 95%. If you look here, and this is the pulmonary artery, which is hugely dilated compared to the caliber of the adjacent ascending aorta, and this also you see the left main branch is markedly dilated. This is diagnostic of pulmonary arterial hypertension. And this is another example. You see the main pulmonary artery is markedly dilated compared to the ascending aorta. The right main branch is considerably dilated as well, diagnostic of pulmonary arterial hypertension. And the chest radiograph, you see a marked enlargement of the main pulmonary artery segment as well as in central branches with peripheral attenuation of the lung markings. Then by CT scan you can easily appreciate that the diameter of the main pulmonary artery is markedly increased compared to the diameter of the adjacent ascending aorta. In chronic cases with increased pulmonary arterial hypertension, there may be developed thrombi within the arterial lumen. As you can see here, this is the main pulmonary artery, which is dilated compared to the ascending aorta. The central branches are dilated, and you see the eccentric hypodense non-enhancing mural thrombus in the left branch. This is pulmonary arterial hypertension, and you can appreciate the dilatation of the main trunk compared to the ascending aorta, and also the dilatation of the central branches. In patients with diffuse pulmonary fibrosis or emphysema or any of the interstitial long-standing lung diseases may develop pulmonary arterial hypertension because of the fibrosis around the peripheral vessels. And at that time, if you have pulmonary angiogram, you can see that the pulmonary artery is dilated, and also you can see dilatation of its central branches, and this is one of the causes of pulmonary arterial hypertension. Thank you very much, and this is the end of the first part of this talk, and the second time will continue the